Good evening, dear colleagues. I'm very happy to introduce this very interesting webinar organized by the European School of Urology and the Andrological section of the European Association of Urology. The topic of this webinar is on the administration of hormones in infertile males. We will discuss about indications, the EAU guidelines, and the expectations. There are two main issues that we will go very deeply and discuss and debate. One is the spermatogenesis that, as you know, is under the control of hormone regulation that involve not only the testicles, but also the pituitary gland and the hypothalamus. And the other important point is that we know that there is an incidence of 20–30% of testosterone deficiency in all infertile men. Well, all this topic will be very well discussed by the amazing experts that will contribute with their speech to these webinars, and I'm very proud really to introduce all of them that you will listen up one after the other. Professor Giorgio Russo from Italy, Catania, and then Professor Zsolt Kopa from Budapest, Hungary, Professor Alexander Giwercam from Malmö in Sweden, Professor Marco Cosentino, again from Italy, Padova, and finally Professor Thorsten Dimmer from Gießen in Germany. So all of these people will amaze you with all their speech, and so any kind of questions you want to ask, you can write. We have the possibility to write question and answer, as you know, and we will take all of your questions, and we will have only 8 minutes at the end to discuss it, but any other important question that you want to ask us, we will answer possibly tomorrow and send you the answer from each speaker. So I'm very happy to get started in this webinar, and the first speaker that I'm going to introduce is Professor Russo from Italy, who is going to talk about hormonal treatment in infertile men with hypogonadotropic hypogonadism. So please, Professor Russo.
Thank you so much, Carlo, and good afternoon to all of you. And I would like to thank also the EAU for this great opportunity. I will talk about the hormonal treatment in infertile men with hypogonadotropic hypogonadism. This is my conflict of interest. But before talking about the importance of the treatment, it's important to understand the efficacy and so the opportunity to control, to understand the efficacy of the two hormones that they act in a pretesticular way, the LH and FSH. The LH is important for the production of testicular androgen, so testosterone. It's important for the induction of virilization of male genital tract for embryonic Wolffian duct. It's important, obviously, to promoting functional maturation of spermatozoa during pubertal development, and also by the regulation of the spermatogenesis and the spermiation and controlling male sexual drive and libido. The LH acts in different ways during the month after the birth and also during the years, because the first wave of acting is antenatal and occurring after 10 weeks of fetal life. And then at the end of the second month of life, in the postnatal period, the axis is transiently activated, and this event is called mini puberty. There is a third wave that occurs after puberty when the axis is reactivated, and it acts by the activation of gonadotropins, the secretion of testosterone, the virilization, and obviously the spermatogenesis that also is maintained by the activation of the FSH hormones. The FSH hormones is in particular is acting by targeting two different cells, the Sertoli cells, but also the bone and the epididymis. It is important in order to increase, to expand the spermatozoa, to set the upper limit of sperm production of each individual. And also, it is important because it regulates the induction of the proliferation and differentiation of undifferentiated spermatogonial cells. When we talk about the definition of hypogonadotropic hypogonadism, it's important because up to now we consider the Tanner stage as the standard stage 3. It's important to define HH. However, there are different studies, and in particular, one study published 2 years ago that define this disease as the presence of a testicular volume less than 4 ml for each testicle, determined by ultrasound, by the demonstration of the circulating levels of total testosterone less than the lower limit of normal 8 nanomole, and FSH less than or equal to 2, and LH less than or equal to 2, and also the presence of the inhibin B levels less than or equal to 35. Obviously, this definition is not yet approved by the EAU guidelines, but I think it adds much more information rather than the use of only Tanner 3 level to the definition of HH. If we look at the EAU guidelines about the cause of secondary hypogonadism, there are so many. There are common causes. Obviously, there are uncommon causes. And we have to consider also the acquired disorders, like the causes induced by the drugs, and also different localized problems that they are present at the brain level. So there are so many. So in our experience, it's important to define them and then to find them, because there are no specific suggestion to the diagnosis of these diseases, but it's important. It depends on the patients that we have in front. Anyway, if we look at the prevalence of hypogonadism idiopathic, it is less than 1%, because most of the causes are related to primary hypogonadism of unknown cause. As concerning the treatment, this table is reported, is downloaded by the EAU guidelines. We can obviously distinguish two different kinds of treatment. The human chorionic gonadotropin, that normally it's a chemical structure purified from the urine of pregnant women. We can use different standard dosage between 1,000 to 2,000 units 3 times per week. The advantages is that it's low cost. The disadvantages is that it is multiple weekly administration. We can also use FSH, the follicle stimulating hormone. There are 2 different kinds of drugs, extractive and recombinant. I will show you later that there are no significantly differences between the 2 types of drugs. We can use at first a starting dose of 250 units of HCG twice weekly, that is suggested. And if normal testosterone levels are reached, maybe we can also increase up to 2,000 units twice weekly. Again, because it is really important to stimulate the secretion of LH and FSH, and so the production of testosterone and certainly cell, and again, spermatozoa. We can also add, as I said before, different dosages of FSH, but also the 75 units or 150 units. It's important to administer 3 times per week. As I said before, there is no significantly differences between the 2 different use of FSH, urinary derived or purified FSH, because the clinical outcomes, they are the same on the 2 different drugs. However, when we look at regarding the use of the double treatment or only HCG treatment, this meta-analysis demonstrated that it is much better to use double administration of the drugs in terms of recovery of spermatozoa, and also in terms of the occurrence of spermatozoa as an endpoint of million per ml. Interestingly, it's important also that the level of LH and FSH is predictor and predictive of occurrence of spermatozoa, and the higher is the LH level and FSH, the lower is the chance to retrieve spermatozoa in the semen. But how long we have to prescribe these drugs? We have to consider that an in vivo kinetic study in healthy men revealed that the total time to produce an ejaculated sperm ranged from 42 days to 76. So normally we have to prescribe for at least 3 months. And it is demonstrated by different studies that demonstrated that after 28 or 40 weeks, we have a significantly increase of sperm concentration, and then we have a steady state. So surely we have to prescribe for at least 3 months. And all the parameters for concerning the fertility, like the motility and then the concentrations of spermatozoa, they increase significantly until 3 months, and rather than there is a steady state. Obviously, the outcome, they are totally different, and it depends on the diagnosis, because if we consider Kallmann syndrome or a congenital syndrome of a congenital HH with absent puberty or with pubertal arrest, we can have an increase of sperms in different months. But again, we can say that after 3 months, we have a very important clinical outcome. So my final message is that as urologists, we don't have to be afraid because of this kind of treatment, because we can prescribe. There are so many studies demonstrating their efficacy. And so again, it's not a matter of endocrinologists or other kind of colleagues, but I think that as urologists, we have to treat these kind of patients. Thank you so much. It is my pleasure to introduce Professor Zsolt Kopa from Budapest for a next speech regarding beneficial effects of FSH treatment in a subpopulations of infertile men with eugonadotropic or hypergonadotropic hypogonadism. Fact or fiction? Professor Zsolt.
Thank you so much for the kind introduction, and very welcome for everybody. So my job is to briefly summarize the FSH treatment effect of infertile men with eugonadotropic or hypergonadotropic hypogonadism. I can't change my slides now. Okay, I have no potential conflict of interest to report. Primary hypogonadism of unknown nose is an unselected patient population near to 2%, and in azoospermic population 0.8%. As we saw, the late onset hypogonadism is in unselected population 2.2%. The testicular deficiency, hypergonadotropic hypogonadism, is usually present with high levels of FSH and LH and with normal or low levels of testosterone. This is very important that in non-obstructive azoospermia, approximately 1/3 of the patient produce a concomitant hypogonadism. So FSH promotes the metabolic support for spermatogenesis. It provides indirect support for spermatogenesis due to the Sertoli cells, due to cell proliferation, and has a regulatory role in the Sertoli cell numbers and proliferations, and growth and maturation, and the release of the androgen-binding proteins. The FSH receptors mediate the transport across the gonadal barrier. Recombinant FSH most recently was reported to have a better safety and quality profile in case of my talk. So FSH is negatively associated with sperm count. We know that FSH promotes spermatogenesis and testicular growth also in the puberty, and negatively correlate with the number of spermatogonia. Increasing FSH serum levels could stimulate the spermatogenesis, but FSH is elevated when the spermatogonia are absent or diminished. And FSH can be in the normal range when the number of spermatogonia is normal, but maturation arrest exists. In non-obstructive azoospermia, FSH levels do not accurately predict the presence of the spermatogenesis. The maturation arrest can have both normal FSH and normal testicular volumes. It's very important recommendation that the total testosterone, FSH, and LH should be tested at least in all cases of oligozoospermia and azoospermia. What we know about the effect of FSH therapy? The first meta-analysis in the recent years was published in 2015 and was conducted of 15 controlled studies, including more than 1,000 couples whose male partner had idiopathic infertility. The sperm concentration was improved as the result of the study with 2.60 million per ml, and there was an improved chance of obtaining pregnancy naturally with the odds ratio of 4.5, and by the outcome of assisted reproductive techniques with the odds ratio of 1.6. The next meta-analysis was published in 2019, and it included 444 patients. There was also found that a higher pregnancy rate with the odds ratio of 3.3 and approximately the same 3 million per milliliter higher sperm concentration. The latest meta-analysis came out in 2020. That was a summarizing of 5 randomized control trials, including more than 600 normal gonadotropic men with idiopathic oligospermia. And there was an improved sperm parameters seen, but in a dose-dependent manner. It means that higher doses had more favorable effect on sperm concentration and also total sperm count. We should consider that the polymorphism in the FSH receptor might also affect the response to this therapy. And also we can state that the specific genotypes might also impact this effect. In non-obstructive azoospermia, this is another case. You cannot find any perfect studies only with FSH treatment, but we can find the treatment with combined hormonal therapies, especially with urinary HCG used in alone or in combination with FSH. Comparative trials included 3,600 patients, of whom 1,400 received any form of gonadotropin therapy. The sperm retrieval rate was higher when we compare it with the untreated population, and the odds ratio of the effect there was 1.115. An average of 17 patients needed to be treated to achieve an additional positive sperm retrieval. When we look at the trials, the beneficial was the treatment in 9 of the 15 comparative trials, and the sperm retrieval rate was increased by 6%. 6% of the patients exhibited a few viable sperm in the ejaculate after the treatment, and 4 couples achieved natural pregnancies. In 2022, there came a meta-analysis from controlled studies, including 985 persons, and the sperm retrieval rate improvement was also with the odds ratio of 1.96, mostly for the normal gonadotropic patients and not in the hypergonadotropic population of the studies. What tells us the recent EAU guideline? The EAU guideline recommends us that in idiopathic infertility, FSH therapy in any formulation has been assessed with some improvement, and the grade of the evidence is 2A. In sperm quality, in increased spontaneous pregnancy rate, and also in assisted reproductive techniques outcome. But no conclusive recommendations can be given on the use of high-dose FSH in idiopathic infertility and prior to TISA or microdissection TISA. So that's why this kind of treatment in this patient population cannot be routinely advocated. The FSH treatment has no substantial evidence of beneficial effect in classical testicular failures, and no data support the use of FSH treatment in primary hypogonadism with a good grade of evidence. FSH treatment can increase the sperm parameters in idiopathic oligospermic men with the FSH levels with the normal range. FSH may improve the DNA fragmentation rates, and as the publications are summarized, a high-dose FSH therapy seems to be more effective. Empiric hormonal therapy for male infertility patients is widely practiced, and we can conclude that FSH treatment results in higher live birth rate and pregnancy rate compared with placebo or no treatment. But there is no significant difference in the outcome. In non-obstructive azoospermia, the preoperative treatment with the combination of HCG was shown to increase the sperm retrieval rate only in 1 study. And the use of hormone therapy prior to sperm retrievals has a limited evidence. The treatment should be confined to clinical trials and not used routinely in clinical practice. That is what you can read in the guidelines of the European Association of Urology. So in summary, we can say that the use of FSH treatment in men with idiopathic oligospermia and FSH values within the normal range Do not treat idiopathic infertility with high dose of FSH. No randomized control trials have shown a benefit of the hormonal treatment to enhance the chances of spermatogenesis rate in idiopathic non-obstructive azoospermia. A meta-analysis has suggested that hormone stimulation prior to the surgery might improve spermatogenesis rate in eugonadal, but not in hypergonadotropic hypogonadal in primary hypogonadal patients. So that's why the recommendation is that do not use routinely medical therapy and hormonal stimulation in non-obstructive azoospermia and hypogonadotropic hypogonadism before the surgery. Do the surgery at first, and do not start hormonal stimulation prior to TASE in non-obstructive azoospermia outside of clinical trials. So that was my talk for today. Thank you for your kind attention. And now I would like to give the words to Professor Alexander Givertman, who is sitting now in Malmö, and he is one of the famous experts also in this question. So Alexander, the word and the stage is yours. Thank you.
Thank you very much. Thank you very much for this wonderful presentation. And I have tested my system here, but now it seems to be a little bit... So, sorry. I'm back on the track. Now we have heard the two speakers talking about FSH treatment in different groups of infertile men. And of course, we all know about the effects of FSH in the testis. But I think that this is an exciting question when we are going to treat a lot of males. If we are going with FSH, do we expect to have the FSH to have some effects without the testis? And I have to declare an potential conflict of interest. I'm a part of a collaboration between Denmark and Sweden in the area of reproductive medicine. And we are getting a grant from Ferring Pharmaceutical, which is one of those companies which are producing FSH. Actually, Ferring has no influence on what we are saying and which types of research we are doing. It's just to make you safe about this. So FSH action in men, you have already heard a lot about this and you have seen pictures. I'm not going to speak anything more about this. But for some years, there have been discussions, could FSH also have action without the male and female gonads? And one of the extra-gonadal FSH effects, which has been suggested now for years, and there are some papers, both epidemiological papers in humans and also papers in animals, which have indicated that perhaps the osteoporosis we see in postmenopausal women is not only due to the low concentration of estrogens after the menopause, but maybe it also could be caused by high levels of FSH, which we see in those women. So, for instance, there's here an example of an animal study where in mice with knockout FSH receptor did have unchanged both mineral density after being castrated. So usually you see, like in the postmenopausal women, osteoporosis, but when you knock out the FSH receptor, the bone mineral density was knocked out. Other types of effect, which also has been suggested to be associated with FSH actions, are the metabolic effects. It has also been suggested, also based on a lot of animal studies, that FSH might be a cause like of disadvantaged metabolic changes, like metabolic syndrome and obesity. So this was another type of effect. And another finding which also speaks in favor that FSH might have effect without outside the gonads is the fact that we find FSH receptor in a lot of other tissues, as you can see here on these pictures, like for instance in liver, you can see it in blood vessels, you can see it in bones, you can see it in fat tissue. So if you find the receptor there, of course, an obvious question is, what this receptor is doing there? Are there some FSH actions in these tissues? And if you look at the human situation, we know some situation where you have like a combination with FSH, which is high, and testosterone is low. In men, for instance, it's, for instance, a significant proportion of men with infertility problems do have low testosterone and high FSH level, which has been mentioned here a few minutes ago. And also, you as urologists see a lot of patients who are treated due to metastasizing prostate cancer. You either treat them with surgical castration, which is not so popular now as it was for many years ago, but also in those men who are receiving GnRH agonist, you can see low testosterone, which is, of course, the goal of this treatment, but also when you castrate the men surgically, or when you give GnRH agonist, you can have a relatively high levels of FSH. And we're also talking now, as Sol told us some minutes ago, that we will maybe treat infertile men who are not having classical hypogonadotropic hypogonadism with relatively high doses of FSH to improve their semen production. So there are some clinical situations where we'll maybe expose men to relatively high levels of FSH, either physiologically or as a iatrogenic effect. Yeah. And when we see at some of the, let us say, side effects or some of the morbidities which are associated with high FSH and low testosterone situation, you can see in prostate cancer patients, cardiovascular disorders, low bone mineral density, diabetes, dyslipidemia, lack of libido, memory loss, anemia, and fatigue. And some of exactly the same problems, this morbidity, you also see in male with fertility problems. And of course, the question is here, is this because of the low testosterone in those men, or could it also be related to FSH? Maybe both, maybe not both, maybe not. Yeah. We have been looking at this issue in a study where we castrated 30 young men. We castrated them with a GnRH antagonist, which causes low levels of both testosterone and FSH and LH. And also did some experimental study, which we did in order to mimic the situation we have created in those young men. And we followed those men here for 5 weeks. First, we took blood samples on them before the chemical castration. Then we took it 3 weeks after the chemical castration. And then afterwards, after these 3 weeks, we gave them a dose of 1,000 milligram testosterone undecanoate in order to normalize the testosterone levels. And after additional 2 weeks, we took new blood samples. So we have 3 blood samples from those men. And half of this, about 30 men, we just only gave the GnRH antagonist and libido. But in the other half of those men, we also gave FSH from the first day in order to keep them FSH levels through the whole period of time, this 5 weeks, at normal level. And in those 33 humans, we look at the hormone levels, we look at PSA levels, we look at the lipids and glucose metabolism, and also make some experimental studies on animals where we gave them GnRH antagonists to a group of the animals, GnRH antagonist with recombinant FSH, GnRH antagonist with anti-androgen, and GN antagonist with recombinant FSH and anti-androgen. And what did we find? Yeah, in the animals, we could see here, and maybe you can see here in the upper level panel, that in those animals who were castrated, we of course could see that who got the anti-androgen, we could see a clear reduction in the prostate size. But when we here gave them anti-androgens and also GnRH antagonist and FSH, we could see some increase in the prostate size, indicated that the FSH may also have some effect on the size of the prostate and on the action of the prostate. What we could see in our young men could see, of course, that the testosterone levels went down after 3 weeks. And then when we gave them testosterone, the canoate, they come up again. LH levels were low during the whole period of time, but FSH levels were, of course, dependent whether they receive FSH, as you can see in the blue line, or they didn't receive FSH. We could not see any effect of FSH on PSA levels. You could see that the red line and the blue line are here very close to each other, but we could definitely see some effects of FSH and the glucose metabolism. You can see those with who receive FSH had higher glucose level at the time when they have low testosterone, and when they receive FSH, they also have a little slightly higher levels of cholesterol, and they also had a higher HOMA index, which lower the HOMA index, excuse me. Yeah. So again, coming back to these different morbidities which are associated with high FSH and low testosterone, although we can explain many of them by low testosterone level, I think that it also should be taken into consideration that high FSH level might also contribute to those different pathological conditions. I will thank a lot of people who have participated into creating some of this data I have been showing to you, and mainly one who has done all the experimental studies, and also the study on the young men who were chemically castrated and received FSH. And I will finish my presentation. And it's my great pleasure to present the next speaker, Dr. Cosentino from Padova, who will talk about varicocele and late onset hypogonadism. And we answer the question, what should we do in those patients, varicocelectomy or treat them with testosterone? Please.
Dear colleagues, nice to meet you. I'm Marco Cosentino from Italy. Today we will focus on an interesting theme, this men with varicocele and late onset hypogonadism, surgical repair or testosterone treatment. We will start with some definition. Okay, we all know the definition of hypogonadism. While adult male hypogonadism or late onset hypogonadism is a reduced testosterone level, excluding any classical form of male hypogonadism, usually in men over 40. It has an incidence of 11-12 people each 1,000 people per year, a prevalence that increases with age, but aging accounts for a low percentage of hypogonadism. That's because we can assist to a small gradual decline of testosterone levels with age. There's a high prevalence in some population, in obesity, diabetes type 2, metabolic syndrome, cardiovascular disease, chronic obstructive pulmonary disease, renal disease, and other. The diagnosis is clinical in absence of any identifiable cause of classical hypogonadism, and as I told, in men over 40. There are a different series of symptoms that we can separate into sexual, physical, and psychological, and they can be more specific or less specific. In general, that's an absolutely short resume. We can consider two lines of treatment. The one is conservative, and the other is defined as hormone treatment, hormone replacement. Why conservative? Because, for example, weight loss and lifestyle changes should represent the first option when we treat an obese or overweight man with hypogonadism. Because testosterone increase is significantly associated with weight reduction. Regarding hormone replacement, we know that any symptomatic hypogonadal man with a total testosterone lower than 12 is a good candidate for hormone substitution. And actually, the presentation of testosterone by gel or injectable have an absolutely good safety profile. How can help testosterone? Can help in different fields. Surely can help in milder forms of erectile dysfunction or reduced libido, intercourse frequency, orgasm, and overall satisfaction, in body composition and insulin resistance, in mild depressive symptom, and bone mineral density. There are some conflicting results regarding weight, waist circumference, and lipid profile. But testosterone is not a common drug. Is a medicament is a drug that we have to take into account some aspect when we give to our patients. For example, we should take into account patient attending fertility or looking for paternity, because as we know, exogenous testosterone temporarily inhibits gonadotropin secretion by the pituitary glands, so resulting in an altered spermatogenesis and altered sperm cell maturation, infertility. We also know that breast cancer is increased, lives with testosterone and its conversion to estradiol. Despite many of us are still considering that high testosterone level are associated to high risk of prostate cancer, literature fails to confirm it. On the contrary, we know that men with low testosterone level have a reduced risk of developing low to intermediate grade prostate cancer. Cardiovascular disease is a contraindication regarding testosterone treatment, because testosterone treatment can cause fluid retention, exacerbating the situation. On the contrary, hypogonadal men have an increased risk of cardiovascular disease, and men with low testosterone level have twice the risk of cardiovascular events and mortality. One of the most common adverse events of testosterone treatment is an alteration of hematocrit, and a number of superior to 54 is a testosterone augmented risk for cardiovascular events and mortality. So it's not cardioaspirin, it's a sophisticated medicament treatment with its absolute and relative contraindication. What's the role of varicocele on it? The role of varicocele is introduced because recently we are switching from the concept of late onset hypogonadism to an organic, functional, physiological hypogonadism. That's because considering that the suppression of axis activity is functional, so potentially reversible. For example, weight loss, increased testosterone level, it's an empiric measure. So considering it, the need for treatment with testosterone has been questioned. Varicocele, as we know, is a common entity with a different incidence in population, 3 grades, being the third visible and palpable. The diagnosis is by physical exploration. Sonography is a satellite option in case of physical exploration unclear. We know it's associated with infertility. There are so many theories regarding the cause, but we still don't have the exact cause of infertility related to varicocele. We also know that it's associated with infertility, with failure of ipsilateral testicular growth, with local symptoms, and hypogonadism. Regarding hypogonadism, evidence suggests that varicocele induce a meaningful decrease in testosterone production. This testosterone production is reduced because varicocele can affect the function of Leydig cell, so altering the production, the biosynthesis of the hormone. But we also know from literature that this process is reversible with surgery, and that surgical repair increased testosterone levels in men with varicocele. we know that varicocelectomy is the option, and that microsurgical varicocelectomy is the best option for varicocele treatment, with the lower overall complication, the lower recurrence and persistence rates. And this table that is recent, straight from a review paper, confirms what some people are demonstrating by public literature. That is, that measuring the testosterone before and after surgery, we can assist to a significant increase in testosterone level after microsurgical varicocele repair. Regarding conclusion, we still miss a cost-benefit analysis for determining the risk and benefits of testosterone treatment respect to varicocele repair. We also need study explaining us the varicocele-related Leydig cell dysfunction, but we can confirm that varicocele repair may be offered to hypogonadal men with clinically significant varicocele, but further studies are required. Thank you so much. Now it's my pleasure to introduce my colleague from Germany, Dr. Dierman, whose title of presentation is Harder Than Mine, Alternative Pharmaceutical Approach for Symptomatic Men with Low Peripheral Serum Testosterone who wants to father their own children. HCG versus recombinant LH versus aromatase inhibitors versus SERM. Thank you so much.
Yes, thank you very much for the nice introduction. I'm a little talking about alternative pharmaceutical approaches for patients who have low testosterone levels and also want to father a child. They can be of very different origins. This is the whole thematic table for today. These are my conflicts of interest. I don't think anything is really related to what I'm talking about today. So if there's a patient with hypogonadism and a fertility desire and has a functional hypogonadism, there's of course not the possibility to administer testosterone because it suppresses spermatogenesis, and everybody actually knows that. So the point is, how can we raise testosterone levels in the blood in serum samples and at the same time do not suppress spermatogenesis? First option is well known from the first talk that we heard today. It's LH or recombinant LH, which is mainly administered, and there's a lot of experiences with hypogonadotropic hypogonadism. And you see as well in the guidelines, as well as in these older studies here from Clich et al., that the administration of HCG or LH can be very successful in stimulating spermatogenesis and restoring testosterone to normal levels in patients with hypogonadotropic hypogonadism. However, in the average patient with low testosterone, there's not much experiences with recombinant LH, and recombinant LH might also be quite expensive in the treatment. So what kind of substance seems to be more interesting is using so-called SERM, selective estrogen receptor modulators, as clomiphene or enclomiphene. And you see here a study of hypogonadal men with the administration of clomiphene doses between 25 and 50 milligrams every second day. And you can see how the testosterone levels going up from baseline and the gonadotropin levels are going up from baseline, as you see here for LH and FSH, and here the testosterone, which shows a significant rise in the study from 2011. Another study using enclomiphene citrate in 12.5 milligram and 25 milligram doses versus testosterone replacement showed a significant rise of plasma levels of testosterone, estradiol, FSH under the therapy with enclomiphene citrate. At the same time, spermatogenesis was not suppressed and showed, in comparison to the testosterone administration, which can be expected, high levels of a good and remained spermatogenesis. Clomiphene citrate in combination with antioxidant has also been tried, and what you can see here, that as had to be expected, testosterone levels and the level of spermatogenesis, like Spearman parameters, as especially sperm counts by concentrations by the million, show significant rise here when enclomiphene citrate was applied. So conclusion, in this quite interesting substance, because it can be applied and administered so easily, therapy with clomiphene and clomiphene at doses used to treat male infertility. Clomiphene is well tolerated and has practically no serious side effects. Based on the reviewed studies in this meta-analysis, there's insufficient evidence to indicate that clomiphene is effective for the treatment of male infertility alone. So it's not the right option to use it in patients who don't have a hypogonadism and low testosterone levels. However, clomiphene citrate is safe and effective and should remain in the armament of the urologist, targeting especially patients with problems and hypogonadal men who wish to father a child who has a fertility desire. Aromatase inhibitors are substances that are a little more difficult to explain from the action and from the effects on hypogonadism and spermatogenesis. As you can see here in this meta-analysis and the collection table, you can use aromatase inhibitors quite well to enhance testosterone levels in serum and maybe also protect spermatogenesis at the same time. However, there's much concern about the use of aromatase inhibitors due to a significant reduction in bone mineral density, which is of course, a consequence of the depletion of estrogens, even in the male body. So aromatase inhibitors may not be the mostly favorite substances to use in this indication. So to summarize, we have the possibility to treat patients with gonadotropins, pulsatile GnRH therapy, clomiphene citrate, or the older tamoxifen, or aromatase inhibitors, and all of them seem to be able to rise in a significant way testosterone levels in these patients who want to father a child. However, the side effects are different. And of course, the administration of the therapy and the costs of the therapy are quite different. Pulsatile GnRH therapy with a pump is quite laborious and difficult to apply for the patient. Oral intake of clomiphene citrate is quite easy. Aromatase inhibitors have this problem that anastrozole and letrozole might significantly reduce bone mineral density, especially when you use it for a longer time. So, and gonadotropins have to be injected, as it said before in the talks that we heard already. Well, to sum it up, and from the EAU guidelines, the recommendation is actually withdraw anabolic steroids if a patient has been on testosterone therapy before, at least for 3 to 6 months. Before considering treatment with selective estrogen receptor modulators, the SERMs, so the EAU guidelines in this condition also prefer using enclomiphene or clomiphene citrate or gonadotropin therapy to induce spermatogenesis. So what is important to know? All options that I've displayed here for patients with somehow normal spermatogenesis who do not suffer from hypogonadotropic hypogonadism. All these treatments are off-label treatments. And due to this fact, oral and parenteral applications have legal and financial implications. And I thought these questions from the audience, we have to be very sure that this is off-label treatment, that it's not registered as a conventional treatment and usually cannot be paid by insurance companies. And the patient somehow should know about that. And of course, also important to know if there's no hypogonadism, just idiopathic infertility with no deficit in testosterone levels. There's no evidence in idiopathic infertility without hypogonadism. So these substances should not treat it outside of clinical studies to just treat idiopathic infertility. Thank you very much.
Thank you very much, Torsten, for your presentation. And now we are at the question and answer section. So we have received a lot of questions, and maybe I can start with reading up. There is a lot of questions about the clomiphene treatment. So maybe, Torsten, I don't know whether you would like to ask them. There's one question here. One second. About whether we should... is it worth monitoring estradiol in the blood during therapy with HCG clomiphene? What to do if estradiol increases? So this is, Torsten, what about measuring? And there was also another on clomiphene. It seems that estrogen level was also increased when given clomiphene. I thought the clomiphene should reduce the peripheral conversion of testosterone to estrogen. Can you take those two questions, Torsten?
Yes, I've
Short
actually...
answer, please.
Actually, I've seen that also. Estrogen levels, estradiol levels seem to go up during clomiphene citrate therapy, and we actually do monitor this. The clinical significance of this is quite questionable, but at some point, if it goes up to values of 80 or 100, you might use aromatase inhibitors as well to reduce estrogen levels. I don't really think estrogen levels range into a problematic field, but it's not really known where there's a kind of cutoff value where you have to interfere.
Good.
Another
Thank
question.
you very much. And there's another question here about what was this about? How to choose the correct dosage and frequency of taking aromatase inhibitors. Giorgio, could you ask? Is this something for you? He's not here anymore. Maybe you could also take this, Torsten, while you were talking. Yeah.
Well, it's not really recommended to use aromatase inhibitors, so I would be a little careful with them. Dosage is 2 milligrams a day for astronazole. I'm not using it very often, so I would actually prefer the SERMs for therapy when I want to avoid given LH or HCG, which is also another possibility. But these are...
Yeah.
So
I have a question here also about FSH therapy for idiopathic oligospermia. This is something for you. I think you will love this question.
I didn't hear you properly. Please, can you repeat the question?
Yeah, considering that FSH therapy for idiopathic oligospermia is off-label, should the patient cite consent for off-label therapy? Please tell us how you prescribe this therapy in practice.
Okay, I think this is different in different countries. So you have to see your own country's regulations. For example, in Hungary, we should have the written consent from the patients. And we also have an official alliance from the National Pharmaceutic Institution, which will give us the allowance to do this treatment. And we have to report all the complications when it happens, when it occurs during the treatment. And we also send some publications and the grade of evidence why we try to do this off-label treatment. This is the regulation in Hungary, but I'm not familiar with the regulations of different countries.
Thank you. Now, I think I have a question for you, Marco, here. It's about varicocelectomy. During microvaricocelectomy, we should deliver testis to assess every possible route of blood return, as proposed by Mark Goldstein, ?
I didn't understand the question.
Yeah. During microvaricocelectomy, we should deliver testis to assess every possible route of blood return, as proposed by Mark Goldstein.
During microsurgical varicocelectomy, there's a total venous ligation with the isolation of artery and lymphatic. And in case of asking regarding the grade of varicocelectomy who needs, we will try to find the best benefits regarding treatment. We have to consider that only varicocele grade 2 or 3 can be the best receiving the treatment. Clinically significant varicocele and not grade 1.
Thank you very much for this answer. And here is another question. Have you seen complication of venous thrombosis in clinical practice after the administration of clomiphene? I don't know, Marco, do you have an experience with this?
No, I have no experience with this, only with varicocelectomy and no thrombosis in.
What about you, Torsten?
Well, actually, you have to see that, of course, these kind of treatments are not used every day because the number of patients is limited where we apply these kind of off-label therapies. So far, I haven't seen venous thrombosis or problems.
Yes, I can also add that we use this kind of treatment in a limited time duration. So we don't have enough experience in longer duration of the treatment. And in shorter treatment duration, we also did not see any thromboembolism complications.
Okay, so it was answered to this question. So it's live, yeah.
May I add
absolutely. Just go ahead.
to the microsurgical varicocelectomies? When you look at the most recent guidelines, this is not already recommended to deliver the testis because the outcome of the treatment won't be better when you deliver the testis. So that was an older, a previous dogma, we can say, but recently it's not necessary to deliver the testis. So when you do the subinguinal microsurgical varicocelectomy without the delivering, then you can have the same good results.
Okay, thank you very much. I know it took all my favorite questions. So do you have some favorite question you want to pick up here?
Well,
yes,
okay. Torsten, please.
I might have an additional comment to the Varicocele question. It was asked if the method according to Goldstein with the completely delivery of the testis and ligature of veins that are coming from the scrotum or the vasa epigastrica is a useful tool for the varicocele treatment. I think that's one of the big advantages of the microsurgical varicocele treatment subinguinally, because after ligation of the typical varicocele veins, you see an enlargement of the testis, and every once in a while, the veins tend to obliterate. And if there's still a blood flow from outer veins coming out from the varicocele strand, these filling of this obliteration will take a longer time or will not happen. So I would actually suggest to do the delivery and get all the veins that you can get from the areas of the scrotum and the vasa epigastrica.
So this is a controversial question, as you see.
Can I have a chance to, if the chairman allowed me, to ask an open question to all of you, so all of five, so anybody can give an answer. There is a lot of debate, as we can see, about varicocele. Every time is such a big issue to be debated. But my question for all of you is, what is your feeling about judging as a treatment varicocele grade 1, I mean the lower case, in let's say also some clinical significant situation, or just to leave it and think about the clinically evidence one? So what is your feeling? What is your practice every day? Everybody can answer, please. No answer. First. Yeah.
Well, if varicocele is related to an alteration in testosterone levels, we can consider also, if grade 1, the microsurgical repair in a hypogonadal man.
Carlo, yeah, my experience, I don't treat level 1. If a patient has oligospermia and astenospermia or whatever, it's important, I think, to check the hormonal status, because maybe that patient has an hypogonadism, so we can treat hypogonadism. I don't think that level 1 it's really strongly related to a reduction of sperms, but it is my only consideration.
Well, I think that we don't have enough. Yeah, please.
I fully agree with Giorgio. This is also our practice here in Hungary.
Varicocele needs to be clinically significant. This means grade 2 or 3,
yes.
Usually not 1, but in some cases we should consider also this.
Thank you. So please, Alexander, just continue. There are some other questions, I believe.
I think, but you are like the chairman now. It's 7:30. Should we continue, or you want us to stop?
Well, sorry, I just missed the time. Well, yes, I think that we are supposed to get finished at this time because that's the time that they give us. So really, I mean, a big thanks from my side, but I believe also from all the attendees to all of you. Really, you did a great job as usual. And so I hope that we will have further chance to all of you to see in the next webinars and with the same colleagues another one. And if you have any other question, we are very happy to give an answer tomorrow. So thank you very much to all of you, and see you soon.
Thank you very much. Bye bye.
Thank you. Thanks.
All of you.
Thank you.
Bye bye.
Bye.